I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
If I could just sort of re-ask her question in a different way, I think maybe what she was asking was, what percentage of mentally ill in this country suffer the kinds of disorders which may or may, which you feel should be in that group that would be responsible to ECT? How many people would be affected by your recommendation that might possibly be effective treatment for them?
I'm not being cagey, and I'm not trying to squiggle away from your question. It is possible, because we have good information that's been collected both historically and been validated and clarified recently by the epidemiological catchment area study, surveying about 20,000 individuals in 4 cities. We have some understanding about the prevalence over a 6-month period of time of those individuals who suffer from major depressive disorders. That's about 3 to 4%, higher than women and men, and varies some with age. That's an average. We're also aware that we have some information about the number of those people with major depressive disorder that have more delusional symptoms or more intensely what we call the endogenous melancholic subtypes. The problem is, I don't think it would be reasonable to extrapolate by multiplying that figure out and say all those people need ECT.
I'm not saying our candidates might be in the pool who might be considered by doctors on one individual basis.
Generally not an indication for ECT. So that a very large percentage of the people who by diagnostic criteria have a condition for which ECT is efficacious on clinical grounds would not receive ECT. So I think any number is going to be misleading. Also, one must realize that it would vary dramatically from setting to setting.
Yeah, but we need, for those of us who are writing stories today or broadcasting stories, we need to have a sense of how many people can be affected by your recommendation. Can you just give us a range?
I think I'm saying that we can.
Would this figure be helpful? I know that you want a figure, and I was aware that you would want a figure, and we thought about what we could give you, and we don't know what we can do responsibly, and it's not just being elusive. 2.4% of those individuals admitted overall to all psychiatric facilities received ECT in 1980, or 33,000 plus treatments in that ballpark. Now, I can't tell you whether that figure is 1/2 of what it should be or twice what it should be. I think that it may increase some or decrease some, but the most important issue, I don't think we can reasonably tell you that there's that amount of pool out there that these people are really being deprived of ECT. I can't do that.
But it is fair for us to ask the question as to what this pool, candidate pool of people that suffer from these disorders. We are able to write in our stories or broadcast them and say, you said that they might not all be candidates, but when people read about this and they have severe depression, they'll say, well, would I be a candidate? They might ask their doctor. We're asking for what that sphere of people might be. And also, you didn't really say whether, you sort of said in the press conference that it implied that it should be a treatment of last resort. I heard you say this morning that you didn't really have a consensus with that. So I think it's fair for us. But this morning in the session, I thought you equivocated on that day when you gave your opening statement. It seemed to say it was treatment more of last resort. I was a little unclear on that. But I think it's fair for us to press you a little bit more about, for example, how many people suffer from severe depression, mania, and some of the times schizophrenia that might be considered within that individual clinical setting. And we'll say many of them will be treated with drugs first. But I think
I am very concerned that any figure I give will be printed as X number need ECT, and I'm very concerned about that. And now maybe that's my imputing inappropriate behavior to what I'm concerned. Perhaps I can share this again with some other members of the panel and they can do more. Dr. Jameson, would you like to talk back to this? Thanks a lot.
No, I entirely agree with you. I mean, you can get statistics. We know the data on epidemiology and the major questions.
Do you know that? Can you answer?
Okay. But yes, I mean, obviously that's public information. I mean, 20% roughly have bipolar manic depressive illness in the general population. Roughly 5% have major depressive disorders. A large percentage of those people are going to be very well treated by drugs or by psychotherapy or by the combination of drugs and psychotherapy. Won't ever need ECT, won't ever come anywhere near the possibility of needing ECT, and I think that's the concern that all of us have.
Well, I think if we're responsible journalists, we understand the concern of being responsible for journalism and pointing that out. Of course, but we have to have a sense. I mean, you're coming out with statements here today. We have to have a sense of how many people could possibly be affected by what you're saying.
By expected, we don't mean that they're going to get it. We can go call the National Institute of Mental Health and look at adequate information. We, as a public service to us,
we have several representatives of the National Institute of Mental Health sitting in the audience who are, I'm sure, have all these statistics at their fingertips. And if you'd like, I'm sure they can give you those. We are concerned about the way the question has been asked. And we cannot say that X% of patients with a given diagnosis would represent X, Y number of people needing ECT. Perhaps.
No one's asked that question.
Would someone else try to? I'd be glad to have anyone on the panel try to answer them differently if you think that's a better way to go.
I think certainly a very, very meaningful question is the question of whether this is a treatment of first choice under some circumstances. And I think it's very clear, and I think Dr. Rose and the entire panel agrees that in some circumstances there are certain life-threatening manias that result in exhaustion if they're not treated immediately and don't respond to medications. That's one group of people. Another group of people are people for whom MAO inhibitors or tricyclic antidepressants cannot be prescribed. This is a very important group of people. I don't think anyone really knows the order of magnitude, the number of people involved, but they are a very clinically significant group of people.
We'll settle for an order of magnitude.
What about the FDA's question of reclassifying? The APA has suggested and asked for reclassification because would you recommend reclassification to a lesser restricted category?
We did not enter into discussion about the restriction, about the reclassification of that issue. That was not a part of our charge. We were not provided with systematic information about that. And I don't think we can give you an answer because we did not debate this. We don't have a consensus on it.
One electroshock treatment can equal the energy of 3 pistol shots to the head.
Dr. Rose accepted 2 pieces of literature for reference. I would hope and you might make copies available for the panel. We're talking about having a police factor information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. I've also included a current Winchester ammunition catalog because it shows the energy with which the bullets have. But running this machine at its maximum brings 201 joules of energy. That is 148 foot-pounds. If you're interested in actually understanding like the truth in lending and what they're talking about, 1 joule is 0.07376 foot-pounds. But what this means is this device, when operated at its maximum capacity, will lift a 1 pound weight 148.7 feet. The energy contained in that is equivalent to 3 25 caliber pistol slugs. Now that is just pure factual data. To give that lifting of 1 pound energy equivalence in informed consent, how could you not do that? And if you're going to give a procedure, the total energy and the total time are the physical parameters that characterize the device. How could you not include that information? And if a doctor prescribes a drug, he has reported. This has been an experimental hazardous device for years now. Why hasn't this information been gathered that we could be talking with concrete, objective facts rather than subjective opinions of psychiatrists and patients?
One electroshock treatment can equal the energy of 3 pistol shots to the head.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment. What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson?
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well?
Now just bite down on it. That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.